Dr. Mohan, I'd like to introduce Dr. NIVEAN. He's an innovator, excellent surgeon, very young but very innovative, and he's a chairman of M&I Hospital, Chennai. He's going to speak on subluxated heart cataracts.
Thank you, ma'am. First of all, it's very difficult to do heart cataracts. And on top of that, very difficult to talk after Mohan Rajan sir showed all the videos on black cataracts. He made it look so easy, I think so. No matter what cataracts I showed, not look hard enough. So, but then basically my talk is just on how to manage heart cataracts when you have other complications associated with it, like a zonal dialysis or a subluxated lens. So then it multiplies the problem. So you can see here is a case of an iris coloboma. You can see the flattening here and the loss of zonules along with the NS3 to 4 brown cataract. So the basic principles of managing any of these cases are going to be the same. Getting the good rhexis, because then it has two roles to play. One, you want a slightly smaller rhexis so that in case you have a rupture or anything, you can do a capture. The second thing is, in this area where the zonular weakness is there, sometimes it tends to run away because there is no support. So we should not tend to go to the periphery. You can make it slight. It may look as if eccentric, but it is actually not eccentric. It is because of the zonules are not there. The nucleus is slightly shifted in the opposite direction. So it gives you a feeling that you're actually going off center, and we should be careful about those two things. The next thing is do everything slowly, careful slow hydrodissection where you can see this fluid wave. I'm not repeating it, and slow rotation. Again, the choice of phaco technique, I always prefer whichever the comfortable surgeon is. So most of the times you do a stop and chop. There's nothing wrong if you're comfortable with the 4 quadrant or the direct chop. But they say when you do the direct chop, there is less energy and less stress on the zonules. Here I do something called the modified chop. When I shifted from stop and chop to direct chop, I haven't found it initially difficult. So what we used to do is make a small burr hole superiorly, if you can see here. So what this small burr hole superiorly does is it debulks the nucleus and also gives us some space to go and embed that phaco tip inside. And almost we have reached halfway through. So this is another point I learned, that you should need a better exposure of the phaco tip. If you have seen all Mohan Rajan sir's video, because initially 5 years back when I used to present, he used to point out and tell me when I used to ask him that I'm finding it difficult to do a direct chop, he says if you have less exposure, it tends to slip when you try to crack it. So have a good exposure, good phaco power can be actually increased even though you're just burying it. So you can have a good phaco power and just slightly lift up and initiate the chop. But here again, because you have the zonular weakness, everything is slow, not too much of a lateral separation. And then slowly dial it. And usually in these heart cataracts, once I get a chop on either side, I usually tend to remove the pieces because I want to have some space there so I can see the red glow and do the other pieces. But in these types of zonular dialysis cases or weakness cases, I do not remove the pieces because sometimes we know where there is loss of zonules, the back can actually collapse. So that can actually get caught into the phaco probe. So in these particular cases, I don't prefer to do that. I like to keep the pieces there inside. So in the phacoemulsification is almost the same, only thing in the back phaco, I would rather prefer to do it slightly in the pupillary plane or even in the Hampton just trying to stay away. And then without removing your phaco handpiece, make sure you inject good amount of viscoelastics because you don't want any flattening of the chamber so that you see those defects there, the vitreous can actually prolapse through that area. And then cortex aspiration, whether coaxial or bimanual, I'm a bimanual coaxial person. So do it gently, just strip the cortex. I call it cortical stripping. Just hold on to the anterior cortical fibers, bring it to the center, then aspirate. Because during cortical aspiration, more zonules can actually break, and then that is when you see what was 1 quadrant can actually extend up to 2 quadrants. The next point is the using of the CTR. So any of these, any 2 clock hours or up to 4 clock hours, I think CTR is really useful and it can be easily done by any surgeon. There are various methods. I use the ski hoop to make sure it goes into the bag. You can also use the forceps to guide them inside the capsular bag. But make sure that the leading haptic goes and make sure it goes into the bag, because sometimes if it goes in sulcus, it's very difficult to retrieve them. You actually lose them. Actually, you'll have to do another CTR. So once the CTR is done, choice of IOL, again a single piece hydrophobic or a 3-piece lens. But the trick here again is to make sure those haptics go into the area where the zonular weakness is. And I try to avoid, usually what we do is the technique of dialing the lenses, but in this case we don't dial the lenses. It is safer to just dip it down and place it and then bend those haptics. And so that is how the positioning of the lenses. So these are just some of the points, take home thing to know when there is a combination of these hard cataracts with the zonular dialysis, usage of a CTR. The next case, I'll just show you if the dialysis is a little more, how you can combine a CTR with a CTS. I think I had the similar video in the other session, managing ZD, I think. So here again, what is different is, because it was a larger clock hour, we're introducing the CTR first to stabilize before even doing the phacoemulsification. And once the lens is kept inside, you can see the maximum area of zonular dialysis is here. So we're trying to fix it along with the bag. We make those reverse flaps for the Hoffman's pocket. And then use the 10-0 proline needle. And using the 23 gauge needle, I'm bringing out the needle. The other end of the needle is brought out through the main wound. And the CTS segment has an eyelet there inside. So this, I'm threading it into the eyelet of the CTS segment. So once the loop is passed inside, the second needle is also brought out through the sclera there. So now when you gently pull this, the entire CTS segment is pushed into the antechamber. And then make sure it goes into the bag in the area where you have the maximum weakness. So once you can see it's inserted into the bag. And then both the ends are tied. You can see the bag is more stable. So I think this is the last case in which you can see sometimes we'll end up with a combination of hard cataract, small pupil, weak bag, and this is like a phacolytic glaucoma where all the leaking proteinaceous materials are in the antechamber. So again, the trick is you make sure that you keep most of the things ready. It is like going to a battle. Make sure you have all the things ready, like your claw lenses or your secondary lenses. So once I wash the antechamber, you can see there's a small hard nucleus. So in these cases, I prefer to do a limbal incision. So in case I want to convert. The third different thing is doing the envelope technique, because I saw some amount of calcification here. So I use the vanas to make a nick. And you should understand in these weak bags, sometimes you don't have this counter traction, so it is not easy. You can see this elasticity of the anterior capsule. So I stopped that side and went to the other side. The other side was slightly better. We were able to get it till that area where you can see the calcification is there. So once that was done, these are the small hard cataracts. Sometimes these are very difficult, and you can see there's so much of space, and the bag is also rolling here. So what I did differently here was just made sure I filled the bag and then put the lens under the nucleus. So what this lens does, if you can get it in the bag, is one, it stretches the bag. I think there can always be controversy, some may not agree. So, but once you put it in the bag, it actually stretches the bag. And then, but make sure that the nucleus is a small nucleus. It cannot be done if the nucleus volume is a large, hard nucleus. So just maneuvering, making sure that I don't lose this nucleus. So then chopping it was difficult because the little space was also less in the antechamber. At the same time, care must have been taken to the iris. One mistake I did here retrospectively thinking is, I think before Mohan Rajan sir pointed out, is I didn't use iris hooks. I think that's what exactly you're thinking right now. So I admit it was a mistake, but sometimes when the adrenaline is rushing and you're doing the thing, sometimes we to forget. But I was careful enough to just to bring it to the antechamber and break it into smaller fragments. So the IOL below is acting like a scaffold. And it is just making sure that the bag doesn't collapse, at the same time not losing these the nucleus pieces. So once the phacoemulsification is done, you can see slight decentration there. That is where the zonules were weak. So in any doubtful cases, in any of these cases, I would always tell everybody to use tricot. Just stain it and see, because no harm. And once you stain and wash it, if there is vitreous, you will definitely see like this, the remnants of the tricot crystal stuck onto the vitreous. So rather than our naked eye, always stain and wash it away to see in any of these doubtful cases. And then using the cutter, make sure the entire vitreous is removed. So one side you use the infusion, and the other side you can use the cutter. Most of the phaco machines have the cutters, so all phaco machines actually have. In this particular case, because it was phacolytic glaucoma, I did a small PI. Others on a routine case wouldn't have done it. So once the vitreous was cut, you can see the lens well centered into the back, and I think this was the best that I could do for this particular case. And eventually she did well up to 624 vision she had. So the last thing I think We were talking about hard cataracts, but when you have a subluxated cataract, the only option is to remove the entire lens and then place it with any secondary IOL. This particular thing is had the new lens that had invented the CMT flex lens. Just show you the lens alone. So once the lensectomy was done, this was a soft cataract, but if you have harder cataracts with subluxation as a topic that was given to me, sometimes you can do SACS and then remove the entire lens. So this is a single piece hydrophilic lens, the T junctions that you can see on either side. So this is a new lens design that we had come up with the treatment of any of the secondary aphakias or even on table when you have such complications. So inject the lens through a clear corneal incision and using this Pranav T-flex forceps, just grasp the head of it. At this time, do not pull the lens, just inject the rest of the lens inside. So once the lens is injected inside, just pull it out of through the sclerostomy. You can see the pop of the T haptics that come out. So the special T just opens up and then this prevents the lens from falling back inside. So this is just an animation clip to show how it is done. So grasp the head and then just pull it out of the sclerostomy. So the same can be repeated on the other side, and that is almost the end of the surgery. So thank you. Any questions or suggestions?
In your first case, like you made your main incision right directly opposite your area of zonular weakness.
Correct.
Because see, most of your chopping is in that direction.
Correct.
Maybe if you had done a
Temporal. How does like? It's a good question, but I don't know. Does it help? Because my she's telling you to avoid that area of the zodiac.
I would also do that. Because you don't want the maximum stress is on the 6 o'clock position. Right. Wherever you are entering is 12 o'clock. Okay? And 6 o'clock. I think you should be away from the area of zone laterals. I don't remember the video.
He's saying wherever the zonular dialysis is, so you.
From 6 to...
Exactly 6 o'clock.
I think I was doing temporal and I mean I was doing superior. Correct.
Was it nasal?
I think it was inferior. I was doing superiorly.
Normally you do temporal.
Normally we do temporal, but any of these complicated cases we prefer to sit superior.
What type of case was it? Was it because of trauma and the subluxation?
The first case was just a coloboma, ma'am. Just a coloboma with a hard cataract with the iris defect.
That's the reason why he could get away without putting CTR, because the rest of the zonules were very strong. Only that zonules were missing.
No, I just meant to point out that where you have a case where you have subluxation, it's better to put
That's a nice, good point actually.
Absolutely. But got away with it because the rest of the zonules were strong. And also when you do it in this degenerative disease like Marfan syndrome and all that, with so much of manipulation, definitely the bag would have come out. Because the rest of the zonules are very strong, he got away with it. What you're saying is a good point.
Yeah.
The other thing
Away
is,
from the-
if you're using this T-flex lens, you had a posterior infusion. For anti-segment surgeons, do you recommend using an AC?
Yes, ma'am. You can do it with the AC maintainer also. In 2 cases, we have done it even after SAC, even without an AC maintainer, just with the infusion itself in the AC. We can do it. The whole point is that the anterior chamber should be formed. Otherwise, it becomes very difficult if the eyeball collapses. So wherever we do a little bit of vitrectomy, the infusion is better actually.
And do you put glue after putting the leaflets?
See, again, here particularly that the lens design is what holds it back less. So the glue is mainly for the flap. So you can use glue or you can use sutures, or sometimes I just cautery the conjunctiva and just leave it like that. So okay, any of the thing. Appasamy is doing the lens. It's available in the market. It's patented and it's come out this year. We had a delay. Yes, ma'am. We had a delay because of the COVID by 1 year, but now it's out.
You are taking scleral flaps now. How can you just put cartilage underneath it? You need to close that scleral flap.
You don't suture the flaps, you're saying, sir. If you're not putting glue.
No. What I'm trying to say is,
We put glue for most.
how will the scleral flap suppose? If you
If you don't.
the conjunctiva, how will the scleral
In my poster, we have seen, I think the normal healing mechanism, because most of the cases we have done 80% glue, but slowly when people start asking, is it necessary to use the glue? So before we were doing sutures, and then certain cases we're just doing only the cautery. I think maybe the autologous blood or whatever is there causes the normal fibrosis that occurs. Here,
What is the gauge of?
23 gauge, ma'am. Yeah.
What is the IOL power calculation? Do you do like normal lens or?
That's a good question. We do a normal lens here. The A constant 118.0 we came up there. But why? Because again it is sitting maybe slightly in front of the back, but we've given a design where there is an angulation. So it doesn't just sit behind the, so it has a slight, so that there can be some amount of pupil dilatation also without any pigment disruption.
So you use the same
Same A constant, no, we don't change. No, ma'am. No, so far. Thank you.
Subluxated cataract well managed. Only thing is, what I would do is differently from what you have shown is that the area in the beginning itself I'll support that either with the capsular hooks or the iris hooks in that area. Okay. Then proceed with the phaco. Then at the end probably I will put a CT.
I was quite surprised also that you got away without any extension of such a large, about 4 clock hours. Then of course the case was a coloboma, that's why you got away with it. But any other case, I think probably you should have to put
Capsular
a CT.
hooks will help in some of these
Capsular
cases when you
hooks
have a
will help.
large
Yes,
thing,
yes,
sir.
capsular hooks.
Yes, capsular hooks definitely will help. Or even iris hooks. Only thing is when you are using, see, iris hooks is not meant for the capsule because it rests on the capsular axis margin. It can
Tear the
Only
anterior
thing
capsule.
is don't keep too much of traction with the iris hooks and don't keep it for too long also. So the two things you should avoid when you are using iris hooks for the capsular bag. So don't use too much of traction, don't keep it for too long. Ideally it will be capsular hooks. The problem is we don't have capsular hooks at that time, or sometimes it's a little bulky.
Bulky.
That is another thing. So iris hooks are much.
Actually, this type of case is probably an ideal case for femtocataracts, because it does most of the procedures, stress on the zonules.
I showed that particular thing, because the rexis is the key thing, and also the nucleus division. You don't have to do anything in femto, because everything the femto the mission does for you. The rexis is done, the nucleus liquefaction is done. You just have to go and pick it up.
Maybe I should arrange a day where I can send my patients across for the femto.
Fantastic surgeries by Dr. NIVEAN. Any other questions?
One more. Dr. NIVEAN, in your last case, where did the vitreous prolapse come from?
That phacolytic, yes ma'am, see I am just assuming in these cases the bags are weak and there are some.
In such a case, putting your lens first is actually quite a
Risky thing. Yes.
It is, that's why I say each case differs, because I have put this and then.
had very poor visualization, so you know.
Absolutely. See, what happened was when you were doing it, you were stretching the bag. The whole bag was going towards one side. That's why there was a vitreous prolapse. That's a little bit risky. I was quite surprised.
I agree, ma'am, but we have done 5 cases in which I've lost the bag in one case.
Done everything correctly. The only thing which he himself mentioned is that he should have used iris hooks.
To see better.
I'll tell you, this is I think which is a take-home message for everybody. If you can learn one thing, that if you have a PCR, okay, the pupil becomes small. Don't try to do a vitrectomy and put a lens. Then next day you'll see the lens on the macula, because you would have put the lens in underneath the rexis margin. It should have been in front of the rexis margin. So at that time use iris hooks. Use iris hooks. You find out where exactly your sulcus is before you put the lens. Similarly, here also, in the beginning itself, you put iris hooks and expand the pupil.
Good visualization is the key.
Visualization is the key. Then you could have gone out with the IOL scaffold technique is a good technique, because the nucleus is small. Nucleus is big means IOL scaffold will be a problem. And you will end up in a cornea which is really
Sometimes during that last piece I've had the whole bag. Sometimes it's not because of that. There are weak zonules, and as you're doing the chamber fluctuation is there, the bag tends to roll and come during the hin. So there have been articles that this is one way that the lens keeps the bag in stretch. There are other questions whether the phaco energy will cause, but I think we can be away from, because the phaco is done mostly in the anterior chamber almost. So it's a compromise between the cornea and the lens.
Yes, one question.
Hypermature Morganian
Correct.
cataracts.
Yeah,
Where you have very
small.
Yes, Doctor.
The nucleus management, proper technique in chopping is the ideal technique. Use the stop and chop is.
I think, sir, because first thing when I started, like comfort of the surgeon, whichever technique you are comfortable will be first. But I think the sir will agree that direct chop, I think, causes one less amount of phaco energy that is used, and also less stress on the zonules. The time, overall time is also lesser.
The problem with this hard blown cataract is that you need to use, suppose we are doing stop and chop, you need to go 90% or 95% of the depth to do a trench. So every time you go do a trench, you are going to use so much of phaco power, and it is going to increase your surgical time. And chopping, it produces less stress on the capsular bag, number one. Number two, you don't have to trench, so less amount of phaco power. Especially with the hyper pulse, the pulse modulation, the micro pulse, which is available in all the machines now, and with the good viscoelastics, you can get away with a very nice clear cornea for all these patients.
I learned a lot from Mohan Rajan sir and
Thank
Sujata
you.
Mohan.
Thank you. Thanks a lot, and thanks. Though we had only a handful of people, it was really good discussion, and thank you once again.